Thank you so much for your kind words. Appreciate that. And I'm delighted to be here. I see some old friends in the audience, long-standing friends, not necessarily so old, with whom I've worked before. And I'm delighted to see so many new faces in the audience, particularly those of you in the child welfare arena, with whom I have not had an opportunity to work, and I hope this will be beginning of a collaboration. You mentioned collaboration being so important, and Jim and I were recently at a meeting where one of the speakers said, and it may be an expression you've heard before, that collaboration is an unnatural act between two consenting adults. And that may be the case. You all know how difficult collaboration is, and hopefully some of the material you'll be hearing today will facilitate that process. For obvious reasons, I'm not standing behind a podium. I thought maybe you'd like to see more than my forehead. So I hope that all of you in the back can see and can hear some of the things I'm about to share during this presentation. During most presentations, we ask you to put your cell phones away and silence them. In this presentation, I think it would be great if you all took your cell phones out. You can still silence them, but we are hoping that we'll have an interactive component by which you can vote and provide your own status and your opinion in certain areas that we'll be talking about. And that'll give us a sense across all of you about where you are in certain areas, what your thoughts are, and where there might be areas of improvement in your specific counties and your specific areas in the state. Let me also say, while we're waiting for that to come up, that there are polling instructions in your packet. It's very easy. You simply text your responses to a number that's provided on this green sheet, and there are some other alternative ways to do that. If you don't have a cell phone, I am sure that somebody next to you will. So you may be able to share that, hopefully, and that would be the first collaboration we'll see today at this forum. So do that. And there are also ways to connect to the polling online as well, and there are instructions on how to hook into, get online through the procedure here in this room. I'd also like to point out that we put on your table some flyers for the Georgetown University Training Institutes that will occur this July in Washington, D.C. How many of you have attended training institutes before? Oh my goodness, only a few. So we're hoping to see many of you there in July. It's a wonderful opportunity for training on systems of care. We have attendees across all partner child serving agencies there. And I think there's a lot of material, in-depth strategies, practical ideas for how you can achieve some of the agendas that are being pursued here in California. And I hope I will see many of my new friends among you there in July. That was kind of a shameless plug for the work we're doing at Georgetown, but we do hope to see you there. So where I'm going to start to talk with you today is really about building blocks. And we believe that you're not starting from ground zero. Your counties have already done a tremendous amount of work to provide mental health care, behavioral health care to children in the child welfare system. So the concepts that we'll be presenting today don't ask you to throw all that out. They don't ask you to start from the beginning with something entirely new. They really ask you to examine what you already have in place, the building blocks that you already have in place within your counties and within your systems. Use that as a starting point and build on them. And the idea really is to improve outcomes, as you all know. Certainly we can all agree on that, to improve outcomes for children, for families, for caregivers, foster families, kinship families, and all those systems who are involved with children and child welfare, and then also to invest your resources more effectively. So here we're asking you, build on what you have. You have a foundation. You have done some work on this before, probably lots of it, and you can improve what you're doing by implementing some of the strategies we'll be talking about this morning. First, I'd like to spend a little bit of time reviewing some of the key points of a system of care approach. Let's see just a quick show of hands about how many of you are familiar, at least at some level, with the concept of a system of care. Okay, so when we get to the poll, I think there'll be a lot of numbers in that area as well. I just want to review some of the key concepts, some of the high points, a little bit of System of Care 101 for you. It's a framework, it's a philosophy. It really has shaped the work of a lot of states and communities and regions and tribes and territories. And we really now are very pleased, it's gratifying to see that there are some elements of systems of care in almost all communities across the nation. Maybe not the whole shebang, but there are certainly elements and pieces of systems of care that have been implemented very broadly, that it shaped national policy, Surgeon General's report, President's Commission, both Clinton's, and then later the President's New Freedom Commission under Bush. And it's really been used also as a reform across child-serving systems. Many of you are familiar with the grants that were given by ACF, the Administration on Children and Families, to use this exact approach and philosophy to create a more comprehensive system of children and families served in the child welfare system. And California was one of the early innovators in the system of care approach. And in the 1980s, you may remember Ventura County. I visited Ventura County early in the 1980s when I was in kindergarten. And you have continued in California to move forward with the system of care approach in many, many areas, as I'll show you in a moment. Here's the definition of a system of care. It's been recently updated. We have added a few elements to it. It's been 25 plus years that we've been talking about systems of care. We added the effective community-based services and supports, which really refers to evidence-informed practices. We added the concept of children at risk, not just for those already diagnosed with serious disorders. And of course, a coordinated network, partnerships with families, cultural competence. And then we added the ultimate goal, of course, what it is we're trying to achieve, which is to improve the functioning and the outcomes for children and their families. In its most simplistic way, I like to talk about a system of care as simply this. It's an array of services and supports. It's supported by an infrastructure that has some very clear elements, and it's guided by a philosophy. So it's not something that's really complex. It's not something that needs to be difficult to understand. It really is this network of comprehensive services, home and community-based services, both in-home and out-of-home as well, and an infrastructure that has many elements, which I'll show you a little bit later, and that's guided by a very well-defined philosophy, which now is really broadly accepted across many child-serving systems. And I want to add here that people don't necessarily use the terminology, the word system of care, or some of the terms that I'll be sharing with you this morning, and I don't really care about that. The idea is the basic philosophy, the basic approach, and we see that, and you'll recognize some of that going on in your own counties, even though if you don't use the words. There's a service array that is typically associated with systems of care. It's a very broad service array, treatment and supports, and an array of home and outpatient treatments, out-of-home treatment services also. But in the home and community-based treatment and support services, you'll see many services that are beyond the traditional services that typically were provided in communities and in states before. We usually saw what you all know: outpatient treatment, 50-minute hours, and clinics. And we saw some inpatient psychiatric treatment, and occasionally, if there was a really good benefit, we saw some residential treatment also being provided. But here is a much, much wider array of home and community-based services and supports that are associated with the system of care approach, and you will see those throughout the presentation, and you will see those throughout your California Core Practice model that has been developed in response to KDA and also in response to your goals of enriching the mental health services provided to children in the child welfare system. The core values of the system of care approach, you're probably very familiar with, because the California practice model has the exact same values. And throughout this presentation, I've tried to show you how aligned the core practice model in California is with the system of care approach. So I don't know if you copied it from us or we copied it from you, but it is aligned. Jim's favorite word, aligned, and we are in alignment. And I thought it was really important to point out that the concepts that I'll be describing are concepts that you already have thought about and that are incorporated into that core practice model that I was very pleased to study before coming here today. Family-driven, community-based, culturally and linguistically competent, those are the three core values that we associate with a system of care. And then we have some guiding principles. You can see that they parallel very closely the guiding principles in your core practice model. We used to have 10 when we started out, and I like to call them the 10 Commandments. We had to expand them to 12 after 25 years. I don't love that quite as much. The symmetry isn't quite right, but the 10 Commandments are still there. We just have maybe now 12. So, and you can see what they are. A broader array of services that are now evidence-informed, individualized, least restrictive, family and youth partnerships, collaboration at the system level, and at the child and family level, where we have new approaches involving child and family teams and all of the systems coming together to provide a coordinated array of services. Some of the new ones that we've added are services that relate to the developmental spectrum that we weren't quite as sophisticated in 25 years ago when we developed this concept. So a system of care should also include services for early childhood, for young children and families, and also for youth and young adults in transition to adulthood. So we added those. We also added what we're looking at as a public health approach. And I think all of you are thinking about that too. That approach has not necessarily been applied to children's mental health in the past. And systems of care aren't necessarily meant to provide all of them, but to link with promotion, prevention, early identification efforts so that we implement much more broadly than just for those youngsters who've already been diagnosed with a serious mental health condition. What it is not, and I think this is really important to understand, again, even if you're not using the terminology system of care is not a model. It can't be replicated exactly the same in every community and every county. It really is not a program. It's a coordinated network of services. So when I hear grantees who have gotten federal grants to develop systems of care, and I will show you a slide about who in California has benefited from the federal funding around systems of care, I really bristle when I hear them refer to them as projects or programs, because they are neither. They are a network of services across systems. They are not a single bounded entity like a manualized treatment. It's not like that. It is designed to have the flexibility and differences across all your counties. It's not going to look the same from one place to another. And most important is that a system of care is not a treatment. It's not a treatment. It's an organizational framework. It's a philosophy. It's an approach. You cannot implement some of the elements of this approach and expect that your child and family outcomes are going to be better. You're missing a link in the chain of logic. What you also have to have are good services. If we don't have good treatment, excellent clinical services, and the kinds of supports that families need, our outcomes aren't going to improve, regardless of how many system changes we implemented in our counties and in our areas. So my equation is system change, practice change, and that's what gets you to improve outcomes. So it's important to keep that in mind, and we have a dual focus of both system and practice. I think in the beginning of our efforts to develop community-based systems of care, we focused a lot on system change. We focused a lot on integration across agencies. We really didn't focus that much on what was happening between children and families and their service providers. And I think we've moved now to realize that these go hand in glove. And unless you focus on both, you will not be able to achieve the goals that you've established in your own counties. As I alluded to already, it's a paradigm shift. It's a vision. It's a framework. It is a way of thinking. It's a guide. It's not a prescription. You will implement this approach differently in every county, in every region, in every state, depending upon your own environment, your own fiscal situations, the target populations that you've prioritized and such. And it's also a multi-level intervention. Changes cannot just occur at the child and family level or at the community level or at the state level, but it really involves all of those changes. And that, of course, is also recognized in your core practice model, which clearly says that this is going to look different in every county based on your particular circumstances and needs and target populations and priorities and fiscal situations and such. The Federal Children's Mental Health Initiative to fund communities and tribes and territories across the country to develop systems of care was started in 1992. And as of a couple of years ago, there were 173 different communities that were funded to do so and got actually an influx of a very substantial amount of federal funds, initially for 5 years and then for 6 years. And there has been an evaluation of that program over the past 20 years, essentially, that's yielded a tremendous amount of data about the effectiveness of the system of care approach. I will just give you the highlights of some of that in a moment. And we found positive outcomes for families, improved systems, better investment of resources, and that's one I'm going to talk a lot about today, because this is a fiscal forum, and I think it's important for you as the keepers of the finances and the financing streams within your state and within your counties to think about, where do I get the most bang for the buck? Where do I put my money to make sure that I'm putting my money in the places and in the strategies and in the services that really are going to achieve the results that you're looking for? And now, all of the positive data has led SAMHSA to begin to support not just these community implementation grants, which they've described as dots on the map. Lots of dots on the map, and they'll show you a map of the United States, and it'll show you all over these 173. I don't know if maybe there are a couple more now, but it'll show you the dots on the map, and that's very nice. We've implemented this approach in many of these communities, but it's not enough, because there'll never be enough funding to fund all communities. So the new funding out of SAMHSA is for what they're calling expansion of the system of care approach. And California has already gotten started in some of those areas, and it's an area that we're delving into much more completely now. I wanted to, and it was my colleague Rich Weiskel's idea, to show you where California has implemented some of these grants. And you clearly in California have been the beneficiary of a lot of federal funds and a lot of federal grants for implementing systems of care. And you can see that from 1993 on to when the latest grants were awarded in communities in 2010, California has been very well represented. And this is in your handouts, and you can refer to that in more detail on your own time. But you can also see that California has begun to take advantage of the expansion grants. There have been 3 planning grants so far in California and 1 implementation grant. Those grants, the planning grants, offer funds for 1 year for a jurisdiction, whether it's a state. In California, there have been counties that have taken advantage of this, but for the most part, it takes a state perspective, and the grants have gone to states for widespread implementation of the system of care approaches. There are 2 planning grants, and Humboldt County got a planning grant for 1 year, and now we are getting 4-year implementation grants to take those plans and actually put them into place in your counties so that you can take the objectives and goals in your plans and the strategies that are laid out, implement them, measure the results, and hopefully, again, achieve the goals that we would like to achieve that the program is designed to achieve, which is the widespread expansion of the system of care approach throughout the country, with the idea that in time, and hopefully in time every state will have funding to expand the system of care approach, but we'd like to see systems of care in every county, in every community, in every state, widespread expansion, and internationally and in the world and in the, in the galaxies. We have some very, very, very big ideas and big plans to work on expansion. And this is consistent with the SAMHSA, the Substance Abuse and Mental Health Services Administration. That was a big one. The SAMHSA. That they have a theory of change, and their theory of change is you start with an innovation and you move through demonstration and evaluation and then implementation in a few areas, and at a certain point we get to the top of that arrow, and the top of the arrow is widespread adoption. And the sense at SAMHSA is that the system of care approach has been tested in many communities for many years, and we are now at the point of widespread adoption. So that's what you're going to be seeing. That's the wave of the future. Ultimately, there will not be individual counties and areas funded, but the grants will focus on that top of that arrow, which is widespread implementation, widespread expansion throughout states, statewide, and again, in large jurisdictions. In some cases, fewer of those will be funded, but that's the direction that the federal government is moving in. So here's a time for the first poll. And you have the instructions about where you can test this to, and they're also posted there. You can text your answers to 22333, and you can enter more than one keyword there. And the poll really is asking you, in your county, is it widely known about the system of care approach? Have you had a grant? Do you actually use the system of care approach? And is there a common vision between child welfare and mental health on this basic approach? Again, not necessarily the words, but the concept, the services, the philosophy. That's the kind of thing we're trying to get up here. And as you begin texting, the results of the polls will show up on that screen, and you can see them, I believe, as the results start coming in. And it'll be interesting to see where it is you're at. Some of you may have had the opportunity to do this before as you looked at the instructions. There you go. So if you text, wow. Liking that. Okay, this is looking really nice. Most of you know, we know that from the hands that were raised previously. Many of you have had grants, but definitely we're using it. We have common vision. That's a really good starting point for your work in terms of the fiscal strategies for implementing approaches that are going to be more effective for serving youngsters and their families involved with the child welfare system, focusing in particular on those with behavioral health conditions. So that's really nice. Let me stop for a moment here. We have a long time to chat this morning. I have a lot of material I'd like to share with you, but I do not want to talk at you the entire time. I hope I'm interesting, not boring, but just in case I am, I'd like to be open to questions or comments after various segments of what I'm going to share with you. So are there any questions, ideas that you'd like to throw out at this point? Comments? So either I've done a really good job or you already know all this information. Well, I'm just going to leave it right there and assume I did a really good job. So, all right. So let's move on. I just wanted to give you a flavor of the results that we're achieving with systems of care. There's a document on this. I'm not sure it's one of the documents that I provided to be put on the website following this conference, but I can put it there. We were looking at expanding systems of care, improving outcomes for children and families. And these are some of the outcomes that we have found. And this has been consistent over the 20 or 25 years of the Children's Mental Health Initiative. We found for children their symptoms decrease, substance use decrease, their school outcomes improve in terms of attendance and grades. We see that their families have reduced caregiver strain. They can handle their child's challenging behavior better. They get more peer support, family-to-family peer support, and they're able to work more. They don't have the kinds of disruptions, than they've had in their work history previously. All of these have economic implications as well, and I'll talk in a moment about return on investment. And one of the latest efforts that we are trying to implement at this point is to do a much more comprehensive assessment of what's the return on investment. If you implement the system of care approach in your counties, in your communities, and you put money into there, what are you likely to accrue in terms of savings, in terms of cost avoidance in the future? And the important point of that is that the return on investment is not just in the mental health system. A lot of the cost savings that we see in implementing the approach are in juvenile justice, are in child welfare, are in special education, are in a lot of the partner child-serving systems that work together to improve outcomes for this group. So the return on investment is a much larger concept than just for mental health and Medicaid, and Medi-Cal I know, but forgive me if I use the word Medicaid throughout the presentation. I know it's Medi-Cal, but it is really much broader. And if we don't open up our analyses to include what the effects may be across all of those systems, both in the short term and in the long term, we're doing ourselves a disservice in terms of thinking about, if we implement this approach, are we getting the most bang for our buck? Are we getting the outcomes we want by investing our money in some places that have repercussions elsewhere in a state system? And I would think that legislatures and policymakers at all levels would be interested in that and not looking narrowly at just one piece, what happens in mental health, what happens in Medicaid, but much more broadly, what are the implications for the taxpayer? The taxpayer doesn't care which system is benefited. It's the big picture that we want to look at. And so others around stability of living, which is particularly relevant for the child welfare population, fewer disruptions in placements, and much more stability in terms of the number of moves that youngsters in child welfare experience. We found, of course, that systems of care improve services, a broader array of services, individualized wraparound approach. You're working on that, I know, in California, more coordination, and some of the values that we talked about before that improve services, and also increased use of evidence-based practices that we're seeing with implementation of the system of care approach. And I already talked about the improved investment of resources, and the reason that we see that, why do we see improved investment of resources? We change utilization patterns. We change utilization patterns. We see better use of Medicaid because we're shifting to home and community-based service approaches. We see decreased utilization of inpatient and residential, and I know you call them group homes here in California, but forgive me because I'm used to just saying residential treatment centers or residential treatment. We see resources that are deployed from budgets that used to support residential treatment and inpatient, that those monies are now being used for services in homes, in communities that, by the way, have more evidence behind them and then do services provided in restrictive institutional or facility-based programs such as residential treatment, RTCs, and inpatient psychiatric hospitals. And as I was talking about previously, cost offsets, cost avoidance. across all child-serving systems. So that's what we're referring to as return on investment. And I know there have been some examples, I'm sure, in many of your communities about how resources in child welfare and mental health and such, Medicaid, have been redirected or are in the process of being redirected from the more facility-based care and more restrictive care and more expensive care into the home and community-based service approaches that, again, tend to have better results. And not just because I say so. Better results in the literature, better results from research, better results in terms of a stronger evidence base. This is the one that really speaks to the unnatural act of collaboration, because implementing this approach really aligns the incentives and the work across all child-serving systems. Has to be a win-win. It has to be what's in it for me. What's in it for child welfare, mental health, juvenile justice, substance use systems. Nobody's going to do this if there's not something in it for them. So here we see aligned incentives, and also across some of the opportunities under health reform that Jim's going to be talking about later. This aligns incentives. Child welfare has less out-of-home placement. Medicaid, again, redirecting resources to less expensive home and community-based. Juvenile justice, education, substance use, the same thing. We're seeing common goals, common results, alignment of goals, and some of the same strategies resonate with all of these systems. So one of the things that we recently have looked at, because we see this again, dots on the map, we see this occurring in some very innovative programs across child-serving systems in the country. But we have moved our focus, as I mentioned in SAMHSA, to expanding the system of care approach much more broadly. And we did a study, and we looked at 9 states. I don't know how many of you are familiar with Office of Management and Budget in Washington, OMB. Yes. Need I say more? We did this study looking at 9 states, all of which had already made substantial progress in expanding the system of care approach statewide. 9 because if you want to go over 9 to 10, then you have to get OMB clearance. So we dodged that by sticking with the 9 states, and we looked at them. And looking at their experience, we found 5 major strategies that can be effective and were effective in these places in terms of implementing the system of care approach more broadly, and here are the strategies. Policy changes, expanding the array of services and supports that are available, and creating financing strategies, providing training, and generating support. Those are the 5 areas that we call the roadmap to system change. And these can be applied at the state level, which in our study generally were, but certainly apply at the county level as well, regional level, county level. And it is not just limited to the concept of widespread expansion of systems of care. These are the kinds of expansion approaches that can apply to the dissemination of any innovation, whether it's in the business world, in the health or social services world. And one point we did an analysis and tried to put together a presentation of how these very strategies were used by Starbucks in their effort to expand their coffee outlets to the extent that they did all over the whole country. Not the country, again, the universe. And how successfully they used these. And if we read the book that was by the president, 2 books that actually he wrote, and if I could remember his name, that would be good, but I can't. Anybody know the CEO of Starbucks' name? No, good, I don't feel like I'm the only one. But his books are really instructive. I'd actually recommend reading the last one because it really lays out the strategy that they used for expansion. And interestingly enough, every single one of these strategies was part of their overall plan to achieving that. And they're all overlapping and interrelated. You can't always separate them out. But if you want to achieve broad-scale change, these are basically the things that you need to do. I'm just pulling out the financing one because this is a fiscal forum, and there are sub-strategies under each of those main strategies that are part of our roadmap. But the sub-strategies under financing are very easy and probably very predictable. One of the most important was Medicaid. Remember the election, Florida, Florida, Florida. So here it's Medicaid, Medicaid, Medicaid. And frankly, Medicaid has been one of the most important and significant funding sources for systems of care and for the services and supports that are provided within them. And Medicaid was the most frequently used source of financing for not just was, for financing the services and supports that we provide with this approach. Grants, federal grants, and I could barely find room on the slide to put all the California grants in there, but grants have also been an important funding source, but not necessarily to fund the services and supports. These are used to leverage long-term funding sources. And we have talked with grantees quite a bit and done some analyses there, and what we've found really is that no service or even no infrastructure element should be put in place with this federal money, without a plan to fund that element of a system of care when the grant goes away. All of you know what happens when you get a 5-year grant. What happens in 5 years or 6 years? Particularly when you call it a project or a program. What happens? You know what happens. Bye-bye money, bye-bye staff, it's gone. And our approach really was to look at sustainability and how is it that the money that's been invested in your community results in a system of care, in a service array, in an approach, in a philosophy that sustains well beyond the 5 or 6 year grant that is provided by the feds. Gets back to the point that the feds have been very generous in this program. I'm not sure what the number was I had up there before, but it was something billion. And that billion, that's a lot of money. I'm not even sure what $1 billion looks like. Look like, but it's a substantial investment of money, and the idea is not just to create something that's going to last for 5 years or 6 years. We've done some sustainability studies, and some aspects and many aspects of the systems of care have sustained, but of course the idea is to use these to leverage long-term funding sources. One of the most effective is the redeploying strategy that I talked a little bit about before, from high-cost services that tend not to have wonderful outcomes to lower cost, more intensive, better outcomes, home and community-based service approaches. Case rates and other risk-based financing has been particularly effective because your provider agencies, your counties, are at risk for all of the services that they could provide, but they have a lot of flexibility because they get a case rate or a capitation rate for everyone that participates in their system of care. They can pool those dollars, and they can use those dollars in a way that meets the needs without a lot of this, without a lot of the restrictions, without a lot of the reporting requirements that you might have otherwise. And particularly important to you is the blending or braiding of funds across child-serving agencies. And of course, between child welfare and behavioral health and Medicaid, those are the major partners where if you think about braiding, it doesn't have to be putting them in one big pool, but there's braiding, there's cost sharing, there are many of other related strategies, and that has been one of the most important financing strategies to implement the kinds of infrastructure and the services and supports that we need to make this work. Please don't glaze over when you see this slide. I just wanted to give you an example of one of the most well-known systems of care. Wrap Around Milwaukee, how many of you?
Okay, not many, so that's good. So I'll tell you a little bit about Wraparound Milwaukee. Wraparound Milwaukee started as one of the first federally funded system of care communities. That could be 25 years ago or something like that. I might have been in grade school by then. But it's a perfect example of a number of the things I was just talking about. First of all, they have child welfare, juvenile justice, Medicaid, mental health, all kicking in funds, and they all do it in different ways. Medicaid provides a capitation for every youngster that's served by that system of care. Child welfare purchases a slot for a youngster that they refer, paying a case rate for that particular child. Mental health is contributed to bill for certain services that might not be covered by Medicaid. For example, their crisis services, which I'll talk a little bit about, and for youth and young adults in transition. And Medicaid provides a capitation rate for every child, one payment for everyone enrolled. And juvenile justice also has the case rate structure. If they refer somebody, they provide the case rate to Wraparound Milwaukee. And all that money is pooled by Wraparound Milwaukee. That functions like a care management entity, like a managed care organization. Who's familiar with the term care management entity? It is essentially a managed care organization. It has the funds that come in, and it is at risk, and it has the ability to provide the kinds of services and care coordination, often using the wraparound approach, to serve those youth at the highest risk for residential, for out-of-home placements, for treatment purposes, many of whom start in those placements and are moved to the community, others that are diverted. But the highest risk, high-need group of youth with serious and complex mental health conditions. And through pooling of the funds, they provide a whole array of services, 200 providers, 60 different services, and as you can see, and I know you're familiar with the wraparound approach, but a child and family team is created. They create a service plan, they coordinate care, they contract out with providers, paid on a fee-for-service basis. They also have family members contractually and such. So this is just an example. There are many, many out there. I chose this because I think it illustrates not just one of these points, but many of the approaches I already spoke about, and to show you how you could create a structure conceivably, if it fits within your fiscal and your environmental context, you could create a structure like this that takes advantage of cross-agency funding and puts it together in a way where you can insist on the kind of outcomes that you'd like, and where the incentives are to provide effective community-based care. Wraparound Milwaukee happens to be liable and at risk for any inpatient, residential, juvenile justice placement, any of them. So their budget, if they put a child in a residential treatment center, and there certainly are some, they have to pay for that. Many care management entities and others don't, that they are not liable for that's taken out of their budgets and of their case rates. But here they are responsible for everything. So the incentives are, as Jim loves to say, aligned with the values and goals of systems of care and of what you'd like to achieve through the KDA system and through your care management model, core practice model. Close. So here's Wraparound Milwaukee. Do you braid funds? Do you redeploy funds? And do you provide higher rates for services, children in child welfare? And I may have a slide that gets to this a little bit later on, but risk-adjusted rates is another concept for ensuring that children in child welfare actually receive the services that they need. And what that indicates is providers will say, if they get the same rate for serving a case rate or capitation or even reimbursement rates to providers if they get the same amount of money for serving them, and we all know they are a higher risk population, then there needs to be enough money so that providers feel they can adequately serve this group. And so the risk-adjusted rate means that as a system, you provide an increase in the rates to youth in the child welfare system that can, in effect, ensure that providers and care management entities like Wraparound Milwaukee and other managed care organizations or systems or regional authorities or county authorities feel that they have sufficient resources to serve this group and also to guard against underservice. We don't want the incentives to go to underservice. So we see some braiding, we see some redeployment, we see a lot of braiding, we see some redeployment, and we see higher rates for children and child welfare to some degree. I think braiding is the most important one. And this poll may come up again, but we'll skip it later. You'll forgive me if I'm a little confused. All right. So now I'd like to stop for a second also. Discussion, questions. Yes, sir.
Yeah, so when you talk about risk-based rates, where is the management of the risk?
Yeah, well, and that varies. In a care management entity, with the example of Wraparound Milwaukee, although right now they are developing in many states and many communities, that's just one example that I wanted to show you visually. The risk is with the managed care entity, the care management entity. You can call it by many names, but they hold the risk. They have a pool of funds. It gets to them in different ways. They create out of all that a funding pool. They have a number of children and families that they're serving. Every service that they provide has to come from that pool, and so they are at risk. If they spend more than is in that funding pool, well, they're out of luck because they are not going to, they're losing money. If they manage those funds well, and if they provide appropriate services to the youth there, minimize residential, minimize inpatient, and substitute the kinds of intensive community-based services, home and community-based services that we know work, then they are maximizing the resources that they have. Many of them have been able to serve additional children. They take children maybe who are at a lower risk, not necessarily already in a residential placement, but those or inpatient and have to be moved out. But those at risk, they've been able to even serve youngsters at a lower level who don't qualify yet for the definition of being in a psychiatric residential treatment facility, PRTF, you may be familiar with that, or in a hospital setting, and they can intervene even earlier. So the funds that they save get redirected, redeployed to more children or to children in different levels of care. Some of them are even creating tiers of care now where their rates for those children are different depending upon whether they are at that highest level of severity in treatment, about to enter treatment, in an out-of-home setting, or at risk. And one of them, Choices, and I can give you more information about them later, they have 4 now tiers of youngsters that they're serving. That help?
When the money comes in the middle once the money is given to them, do you have to track how those funds are used? Or do they just get to spend it however they want?
They have tremendous flexibility as to how they spend that money, but yes, it has to be tracked. In terms of Medicaid, they still have to provide encounter data just to show what they are providing. In terms of other agencies, I do believe they submit reports that show where the monies are going. However, the flexibility in how they use those funds is much greater than if you had all these siloed individual funding streams coming into play, and they would say, as many of these others, in New Jersey, in Georgia, in I can't, Wyoming. I can't think of, I will later think of a number of states that are doing this, but they will say that the flexibility in using these funds is what makes the difference in them being able to serve these kids well. But yes, they do have to submit reports about how the funds are expended. I think the encounter data in some of them are the ones that are more difficult, particularly in fee-for-service, units of service provided in Medicaid. A number of these have developed their own management and information systems, clinical care manager and others, that really have helped them to track this kind of service delivery with very little effort.
I have a quick question.
Yeah.
If you could go back to the slide on the Families United piece.
Yeah. Yeah.
Is that 400,000 or is that 100,000?
400,000.
Okay, 400,000.
Yeah.
Now, is that contracting?
Yeah.
The county's contracting with Families United,
Yeah.
and it seems like it's about what, 1% of the 48 million?
Yeah,
Okay.
Wraparound Milwaukee is a family organization, contracts, Wraparound Milwaukee, by the way, is run by Milwaukee County. It is one of the only care management entities, CMEs we're calling them, that is operated by a county agency, and it's done very well. They contract with them for a variety of things. They often provide peer support services. They pay them for involvement in all their policy making in their governments and such.
And so that is a big piece in all of this, I think, and the county's having a difficult time contracting to get parents paid or other family supports paid in the child and family teaming.
Mm-hmm.
And so that seems like we're trying to expand that. And do you have any suggestions for counties to maybe contract with different agencies to make that more rich or enhance that?
There are now examples of many, many states increasing every day where family and much lagging behind, youth peer support is a billable service under Medicaid. And I'll be able to give you examples of the language that they use, but they have been billable. Sometimes under these waivers, sometimes with other authorities, but there is really a move to getting family support, and peer support for youth covered under Medicaid.
Mentioned that with the Wraparound Milwaukee that they contracted out for services, including with families. Would that include like a 1099 going to treatment foster care providers? And what are some examples of incentive-based contracts that they utilize?
Yeah, everything is incentive-based. They contract with providers that meet their standards and produce results. If the results and outcomes aren't good, those contractors are no longer in the system. And all of their actual services, except for the wraparound facilitators, intensive care managers, are contracted out. The other service, I'll talk about this in a minute, but the other services that they provide that are essential are the mobile crisis response and stabilization. So some of the peer support, family peer support, youth peer support, mobile crisis stabilization, wraparound planning, intensive care management is through their own organizations, and their child and family teams then develop a plan which allows them to, and those plans, by the way, are considered approved by Medicaid so that they meet medical necessity criteria. If you have a plan, child and family team created it, it's approved, it met criteria, except if it's RTC or inpatient, it has to go through another level of approval, sign off by a psychiatrist or a psychologist, but they're approved, and they then pay providers on a fee-for-service basis. And the care manager and the child and family team monitor this. Okay. So I want to go briefly through the work that we've done on what Medicaid how to make Medicaid work better for children and child welfare. And some of this we've already touched on, so I'll go through it rather quickly, and you have some of the slides as resources within your package. But the background is that we all know that children and child welfare are at very high risk for health needs, mental health needs. Most of them are eligible for Medicaid, and a customized benefit has a tremendous impact on the child welfare outcomes that you'd like to achieve: safety, permanency, well-being. And we found some efforts in some states to do something about it, to begin to craft their Medicaid strategies and benefits and approaches and requirements to better meet the needs of this group, to make Medicaid work better. And the Casey Foundation awarded a contract to me and my colleague Sheila Pyries. Many of you may be familiar with that name. She's done a lot of work in mental health and child welfare. And what do I keep doing here? And the most important strategies are the ones listed on the left. I'll touch on each of them briefly. These are the strategies that we found to be the most important ones: Medicaid, eligibility and enrollment screening, services, individual planning, and so on, providers, medication, and so on. And the questions that you need to ask yourself when you're thinking about this is, what do you want to finance, number one? For whom? For whom? Who are you looking, what is the population? You don't want to just finance, plan a financing fiscal approach out of context. So, for whom and for what? And these strategies, the reason I put those questions there is because these strategies apply not only to Medicaid or Medi-Cal, it applies to any fiscal strategy that you will put into place to serve children in the child welfare system and their caregivers and families who have serious and complex mental health conditions. So I'm talking about Medicaid. That was our project, but it goes well beyond Medicaid. Any of the financing structures and processes you use should incorporate these kinds of strategies. Medicaid financing, a couple of things to point out, is that child welfare and behavioral health agencies have combined money, pooled money. By doing that, they increase the federal share of Medicaid that they're entitled to. It's kind of a no-brainer. They have raised money to expand their service rate and improve it. Things that were funded only by the state before now receive a much larger share of federal participation. And there are examples of that, it's particularly in New Jersey. And by the way, the examples are just coming from the 4 states that we looked at. There are many more, and many more states are doing this, and you may be doing some of this. But the examples here show how they've done that. They've pooled funds. They have been able then to draw down federal funds and expand the pool of money, the budget that they have available to spend on services. Risk adjustment. I've talked about risk adjustment before. If rates aren't higher for youngsters in child welfare, and they're more expensive to serve. They have higher needs, they have more complex needs, so we need to provide higher rates for youngsters in this system. One of the interesting approaches here is in Arizona. They have devoted one single health plan that in their Medicaid managed care system that's responsible for children and child welfare, and they do have a risk-adjusted capitation rate there. So this was the poll that I think we already did. So I guess I didn't forget to put it in the presentation, which actually is comforting to me. And we can skip this one and move on to the next strategy, which is eligibility, enrollment, and access. And it's how children and child welfare get services that they need in behavioral health systems, and sometimes health too. We know, again, that nearly all are eligible. There's presumptive eligibility of children and child welfare in many states. If you're in child welfare, you're presumed to be eligible for Medicaid. It may not be true in a few cases, and that may be corrected later on, but presumptive eligibility helps children in child welfare to get services in health and in mental health very quickly. We also talk about coverage beyond age 18. What is it now in California? You can serve children in child welfare up to 21? And, you know, in 26, it's going to be required under the Affordable Care Act. Not sure when that goes into effect. This year, better get ready. You're going to be serving children up to age 26. Access. Access is a big one. And your core practice model already addressed this. And we found some interesting approaches about how children in child welfare access services. There are liaisons that are placed in child welfare offices who can work, behavioral health liaisons, who can work with child welfare staff, who are very familiar with the behavioral health system, the mental health system, how to access services, how to identify problems, how to link these youngsters with the appropriate services that they need. And Michigan's a good example where they have access staff. They refer to them as access staff. And they are placed in every child welfare office, and they help to translate the requirements to child welfare staff. They work as partners, and they are billable under Medicaid, under an existing code. It's called assessment. So if you creatively look at your Medi-Cal codes, you can see that a lot of things that are mentioned here you can already bill for without much difficulty. The question over here.
My question was whether Michigan is able to do this under that 1915C waiver just for Michigan, or is it broader?
Oh, you're going to do that then.
My question is whether,
I don't think that, or let me back up. My question is whether Michigan was able to bill for those services under the 1915C waiver, whether that waiver is just applicable to Michigan or whether that's more broadly applicable.
In Michigan's case, it was under the 1915C waiver. Jim may be talking a little bit about, is it more broadly now?
Well, the question was around the assessment part, at the co-location of a child welfare worker.
And
That was
using-
done actually originally with federal mental health block grant dollars. We used block grant dollars to co-locate a worker, and
moved to
then
Medicaid.
then they moved, and it really was not under the C waiver, but it was under the rate cell that was developed after I left. So it was under this rate cell that they put in the
Which is the general
assessment.
Medicaid
Yeah,
plan?
yeah.
Okay,
It was-
so.
It's an
you could do
enhanced
it.
thing.
Yeah,
that
no,
we-
you
we
could,
can talk about.
because if you
So
have
you could do it, yeah.
If you have a code under Medicaid for assessment, you could bill something like this under assessment. Screening is a big one, and I know that's required also in the core practice model. One of the screening and linkage to appropriate services that I think is particularly effective is in Arizona. They developed what they call an urgent response strategy, and initially folks had to be screened within 24 hours. Now it's 72. They found that to be a little more realistic, but they call it a fast track. And through that initial screening, the urgent response, it's on a fast track, it's identified. Youth and child welfare can be referred very quickly for mental health response if they need it. And there are a couple of other examples here where it's required in 30 days. Another one I like is the child health units in New Jersey, where this unit, staffed mostly by nurses, but it exists in every single one of the child welfare offices throughout the state. And they screen children coming into child welfare, not just for behavioral health, but also for health. And they make sure that the appropriate referrals to the health plans are made, and also for mental health screening. So I think that's a particularly useful strategy. And some of them are using standardized screening tools, some not. In a couple of states, they have a set of screening tools that can be used, and they're offered to all of the agencies involved. They can choose one, but in New Jersey, they're using the CANS. Familiarity with the CANS? Yeah, and there's a customized version of the plan that was developed for the child welfare population. They do it for juvenile justice and such as well, and they've developed customized versions of the CANS for all of these different uses. Coverage of services, another really important one under Medicaid, robust benefit. Robust mental health benefit is key, comprehensive, covers supports, and additional to the to the ones that are more traditional that I noted before. And how have they done it? They've added new services to the state Medicaid plan. They've used existing codes to the Medicaid plan that seem closest, and they've had people bill under those. They've used rehab, targeted care management, EPSCT, waivers, and Jim will talk to you about new opportunities under the ACA that could be used for this purpose. And then state funds in many states, like block grant that Jim just mentioned, are used to fill in for some of the things that are not covered under Medicaid. And there's a list on the side that they were on the list of services provided anyway, mostly in systems of care. But this is a list of services that are typically added to the Medicaid array of covered services, Medicaid benefit. These have been added, and through those different mechanisms, existing codes, new codes, and also using available waivers. Another one, I just wanted to list here some of the services that are really important for child welfare. And rather than going through the definitions, I think you all know the definitions for these, but the ones that are most important for the child welfare population, in our view, are the in-home services, family peer support, and we're really behind in youth peer support, but hopefully that will come up soon, and mobile crisis response, mobile crisis teams that go into the community, into foster homes, into residential treatment, into emergency rooms, 24/7, available to work with a child and family, avert the need for hospitalization. They have been tremendously effective, and they also can remain with families for a period of stabilization as well in some cases. Evidence-based services also covered in Medicaid plans, sometimes with a special code, sometimes under family therapy. MST can be covered under family therapy. The therapeutic foster care, the clinical services can be covered as part of that, and the room and board through other mechanisms. And and the covered services, again, intensive care coordination, and you can see how it dovetails with your practice model, low care coordinator to child ratios. And one of the approaches I like is in Arizona, where every single child is responsible for a wraparound plan. If they're not at a high level of severity, the wraparound team, child and family team, could be just a family member and a clinician. But as, of course, we work with those that have serious and complex needs, it would be that full-blown wraparound process. Hands-on wraparound process or something similar used in your counties, so that's good. Okay. Wraparound approach, next. You may know already what that is. It's individual care planning, child and family team. They develop a plan. It's considered authorized. Plan includes families, youth, all involved providers. That plan is monitored, it's coordinated, and you see that, again, it is the foundation of the practice model in the states that we looked at. Many of the states are looking at psychotropic medication, important for the child welfare population. You're probably familiar with the GAO report that found over-medication, multiple medications, medications used that have not been tested for young people, and there's been a tremendous effort to look at ways in which those could be monitored between child welfare and between the Medicaid system. There's been child psychiatrists hired. There have been quality collaboratives developed. There have been child psychiatrists hired by the Child Welfare Agency to look at this data, to match it with Medicaid claims data, and to find the outliers so that those could be contacted, those could be worked with to try to address some of that. And providers is one of the last areas I'd like to talk about. We know that child welfare children need specialized providers to deal with some unique problems that they have, whether it's sexual abuse or attachment disorder or trauma. and a number of the states that we looked at have worked on that. Specialty provider networks, they're monitoring it, they have to provide it, or get providers out of network to make sure that children and child welfare have those services. And also, in some cases, there's been a requirement for the mental health provider networks, the management of that, whether it's a regional authority or a CME, to make sure that they have those providers and that they contract with and make them eligible for Medicaid billing providers that have worked with the child welfare agencies also previously to serve those populations. Practice protocols have been used. Training for providers on the needs of the child welfare population are important, and performance tracking also important. Do we have data on what is provided to the child welfare population? Is the data on outcomes and service utilization and cost separated out for the child welfare population? And how would we know that if our management information systems don't capture data that is unique to the child welfare population? Cross-agency data has been a challenge, you probably know that. But there have been some strategies, effective strategies in some states to try to blend in some ways to make it easier to share information across Medicaid, child welfare, and behavioral health. Last poll. And I'm going to let you put your responses up there, but move on to a few things that I'd like to talk about just to close. And here you're looking at whether you co-locate, you have screening tools, do something around Medicaid training, have specialists and such. So while you're texting, I'm going to talk a little bit more. One of the things I wanted to touch on with you as we close is on a new informational bulletin that has been released by the Federal Centers for Medicare and Medicaid Services. Many of you seen it? The bulletin? Okay, most of you haven't, so this is good. The CMS came out with a bulletin telling states how and encouraging them to cover a range of the services we talked about under Medicaid. This is a huge, huge, huge step forward, that we have actually the sanction of the federal CMS to ensure that this wider range of home and community-based services are included in your Medicaid plans. The polling categories are there too, so, and on your handout. So if I move along, you can see them there too. But this is the Medicaid bulletin. It was joint from SAMHSA and CMS. It was based on the outcome data I reviewed with you before, and also data from the Psychiatric Residential Treatment Facility Demonstration Waiver. Many of you may have some familiarity with that and can learn more about it through their evaluation. It's in your packet. It's not in your packet, but we could certainly, it certainly can be on the website. And this is the benefit array that they put in the bulletin. All of the things that we, not all, but many of the things that we talked about before are in the bulletin. So you can see respite, mobile crisis, flex funds, trauma care, home-based, all of the peer support, all of the things that we discussed can be covered by Medicaid. And this informational bulletin really shows states and gives them a sanction, really, to go ahead and do these. And I put definitions in here of the services, but I think some of them I provided earlier. This is something that you can peruse later on. But here are some of the definitions of what they mean by the services that were put in this informational bulletin that would be services and supports that could be included in your state Medicaid plan. So intensive care coordination, which is essentially wraparound, the intensive in-home services that we also discussed, where teams go into homes for therapy, skills training, behavioral interventions. We have peer support. We discussed that. Here are some of the functions that are included in peer support, both youth and families. It's getting people with lived experience. Lived experience is a new buzz expression that we're using, that people who have gone through this can show, who have walked in those shoes, can mentor and guide families and youth through the service delivery process and the systems that they'll be facing. Mobile crisis, talked about this before too. I don't know if I mentioned that in addition to providing mobile crisis services going into homes, going into other community settings, in some states, the crisis team is allowed to work with the families and youth for an extended period of time. I think it's 90 days in New Jersey, different in different states. And in Wraparound Milwaukee, they have one-to-one crisis stabilizers. And they can remain with the child and family until we make sure situation is de-escalated, that they can be linked with ongoing services and so forth, and that their acute needs are addressed, and that they then can move into ongoing services to support them as they move along in the future. And flex funds, any of you are using those? Yeah, some will show you a little bit about that too, but used for a whole variety of purposes that fill in for things that are not necessarily clinical services, but can make the difference, for children, to keep them in their homes, keep them in their communities, one-time expenses, therapeutic camps, tutoring, mentoring, a whole range of things that we know sometimes make the most significant difference in keeping youngsters in their homes and in their communities. Trauma, huge for the child welfare population. Another one that the informational bulletin includes, and some others that you could put in your state Medicaid plan, like mentoring and supported employment and consultation. And another poll, last poll of the morning. Which of these does your county cover? Which of these are covered, provided in your individual counties, which will give you an idea of areas that you might want to pursue in the future. And again, you can see the categories on the other screen. So I'm going to just conclude by showing you the Medicaid authorities that can be used to cover these kinds of services. Some of them are waivers, some of them are new opportunities under the ACA, and Jim will touch on those. But there are many, many authorities that can be used under Medicaid and under the ACA that can enable you to really broaden the array of services and supports that you provide under Medi-Cal, and that can, again, make a huge difference for children in child welfare. And it's important because of the flexibility, that you can achieve in your service provision for children in child welfare who have significant behavioral health treatment needs. So I'm wanting to suggest that you build on what you have. We're not throwing out the baby with the bathwater. You have a foundation in your counties. You're doing many of these things already. You may not think of them in this way, and hopefully this has given you some ideas of what you might look at in the future to improve the work that you're doing with the child welfare population and the group KDA that rises to the top in terms of the highest level of need, the most severe and complex challenges. So I think we have a few minutes for questions and answers, yes or no? 5? Okay, any questions, comments? Well, again, either I did a great job or, or you're bored.
We have one here.
Oh, I'm sorry. Thank you very much. Thank you.
We're from Mariposa County, which is a small rural foothill county. One of our biggest challenges across agencies is the permission from the families to share information.
Yep.
So we're looking for an effective form or way to get permissions to get families to let us collaborate.
Yes, if somebody will remind me, because I can't remember anything anymore. But if somebody will remind me, we have We have examples of some of those forms, particularly from Wraparound Milwaukee, and we'd be happy to share them. They have not had a problem with cross-agency exchange of information using a common consent form that has been very, very effective, and there haven't been any problems there.
The problem comes down to like county councils and things like that, county councils being able to feel comfortable with that information being shared across lines, so, or amongst agencies. So that's, each county's a little differently when it comes
Yes.
to how conservative they are or how liberal they are when it
Yes.
comes to sharing that
Yes.
information. So.
Well, obviously, if child welfare and behavioral health and Medicaid agencies are going to work together, unless there's some way to track who's being served, what the outcomes are, and such, the barriers are going to be particularly significant. And I think there are legal and some procedural ways that can be dealt with, generating support and helping some of these officials to understand how those legalities and ethical issues are being dealt with in some places has had a tremendous effect. So I'll be able to talk with you, send you forms, and even refer you to some of the folks, perhaps in some of the systems of care we work with, to help you learn how they do that. Time for one or two more? Rich?
I know during your presentation, Beth, that of all the various strategies, you stressed the importance of the mobile response capacity. I know many California counties, including our own, has attempted and struggled with getting these programs, which really are effective, to be financially viable. They're extremely expensive to run and sustain, and I want to know if there are also examples, not just of how the programs operate, but of how to fund them in conjunction with other services so that they don't break the bank for a particular county.
Interestingly enough, they're one of the most cost-effective aspects of the strategies that I presented. The reason is the data are so clear. The difference in emergency room use for children's psychiatric reasons, the difference in psychiatric inpatient hospitalizations, both that result from emergency room contact or independently of that, are very, very clear opportunities to show what money has been avoided, what costs have been saved. And those expenditures far succeed. The expenditures are far greater than those that are used with the diversion that can be achieved with these others. And so that's one of the easiest ones to justify because it's so blatantly clear. So it's a matter of keeping that data, looking at rates of inpatient psychiatric hospitalization that evolve from an emergency room visit, looking at what psychiatric emergency room visits look like for children, monetizing those costs, and then showing very clearly by the way, with your county commissions, with your state legislators, all of that, a one-page paper providing this data, boom, 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 is the most effective way to show them this is what you're spending. If you do this crisis team, this is what you can save. You can use data initially from other places that have done that. It's always helpful to have a little bit of data from your own backyard, but that's one of the easiest ones.